Hello, everyone. Like Wade mentioned, my name is Amanda and I am a speech pathologist and postdoctoral research fellow with Cerebral Palsy Alliance in Sydney, in Australia. And my PhD research was all about dysphagia. It was specifically for babies who have dysphagia. But today we'll be talking about babies all the way through till the end of life. So strap yourselves in. As Wade mentioned as well, more than happy to answer questions. If you're not comfortable asking a question today, my email is there, so feel free to send me an email with your questions if you'd like after the fact, or if you'd like a copy of the references from today, I can send those through to you as well. So we are talking about eating, drinking and swallowing across the lifespan for people with CP. What could go wrong and ways that we can possibly help. I'd also like to acknowledge the people of the Gadi land of Eora, where I'm on, and the people of the lands that you are on as well today. We can learn so much from them and their culture, particularly around mealtimes and inclusion. So I think that's something to carry with us for the rest of this presentation. So, what may go wrong? Well, dysphagia is the main thing, which is the medical term for difficulty eating, drinking and swallowing. For children, there is a broader term called pediatric feeding disorder, which encompasses fussy eating, refusal and other digestive issues and psychosocial issues that may be impacting too. But today, the main thing that we will be referring to is dysphagia. It's also known as oropharyngeal dysphagia, or OPD. So first up, I want to do a little activity with you. I can't see any of you, so I trust that you will all follow my instructions. I'd like you to tip your head back all the way, like this. Go on, hold it there and swallow. It's an uncomfortable, almost impossible feeling, isn't it? This is what it feels like for many people who have dysphagia. And we swallow 900 times a day. Imagine experiencing that feeling every time you swallow. A successful and safe swallow requires perfect coordination of 31 pairs of muscles and 6 cranial nerves. It's a very complex skill and requires such great coordination of all of your muscles. And because people with cerebral palsy have difficulty controlling their muscles, it's not surprising that dysphagia is very common across the lifespan and across all the range of severity of cerebral palsy. So all the way from GMFCS level 1 through to GMFCS level 5. So in children, the prevalence ranges from about 30% all the way through to 100% of people who are GMFCS levels 5. And in adults, it ranges from about 7% all the way through to 94% in those who are GMFCS levels 5. There are several risks that come with dysphagia. One of them is malnourishment. So you can imagine if it's uncomfortable for you to eat, you're at risk of food or drink going down the wrong way into your lungs. It's likely that you will eat less, at least eat less orally. And so malnourishment is very common. 30% of people with dysphagia who have cerebral palsy are below the 3rd percentile for their weight and their growth. And growth faltering for children is very common. There is a risk of further disability because if you're not getting the nutrition that you need to grow and develop, it can further impair your musculoskeletal development, your cognition, your health, and your immunity. And there's the psychosocial impact that comes with not being able to eat and drink like everybody else around you. It can come with stress and poor quality of life. It can also come with social withdrawal and exclusion, because if we think about a mealtime, think about a mealtime that has been quite special to you. Sometimes it's about how great the food is and how much you enjoyed, how tasty the meal is. But mostly it's about the social interaction that comes with it, the people that you were there with, people that you're speaking to, and the environment around you, the lovely view, the candlelight, the tablecloth, all of those things come into play. And if you're worried that people are going to look at you funny when you're eating and drinking, or if you're coughing for a lot of your meal, or if it's just difficult and it's slower for you to eat, there are risks that you might be excluded or not want to take part in meal times with everybody else. And then there's a risk of aspiration pneumonia. So this is a chest infection that can develop from food or drink going down the wrong way into your lungs, which is a significant risk of dysphagia. It is also the second most common cause of death for people with cerebral palsy. So it is very significant. There are lots of systems within our bodies that influence or cause dysphagia, and these are some of them. So neurological, we know everybody with cerebral palsy has a neurological component, and that can influence their dysphagia. Respiratory, so if you have any difficulties breathing, either when you were younger or as you've gotten older, that can also make your risk of dysphagia higher. If you have any gastrointestinal issues, digestive issues, motility issues inside your gut, that can increase your risk of dysphagia. And people with cerebral palsy, it's not just their external muscles that they have trouble controlling, but often the internal muscles of digestion can be affected as well. Cardiac conditions can impact, again, very common with CP. Somewhat less common, but also prevalent, are structural causes of dysphagia. So it could be a cleft palate or a tracheoesophageal fistula, or a tongue tie even. And then as well, it's experience. So if you're at a high risk of aspirating or choking, there is a risk that you are not going to progress as quickly with the foods that you are eating and drinking. You might stick to puree or easier foods because they take less effort for you, or you might be prescribed things like thickened fluids that make the task easier. But what happens with these is that you never get the chance, or you get a limited chance, to practice those harder skills. And that's the main thing that I want to take away, that I want most of us to take away from today, is that if you don't get the opportunity to practice the real task, it's very unlikely that you will develop that skill. So experience is so important. And because we know there are significant risks that come with dysphagia, we need to be quite cautious. But I think historically, particularly as a profession of speech pathologists, we have been perhaps overly cautious because we don't want to risk developing a chest infection. We don't want to risk choking. We want to make sure that people are getting the nutrition that they need, so we make it easier for them. But sometimes we forget, or we don't get to see them as often because of funding or their health system structures, that they don't get the same intensive follow-up that they would need to be able to safely challenge some of those skills. So some of the signs of dysphagia that you might experience or that you might see in someone who has CP include coughing, but not always. This is the main sign that we look for. But if you don't have coughing, it doesn't mean that there is no sign that there is no dysphagia or no aspiration. Often, quite often, in fact, in children who have cerebral palsy, 99% of them don't cough. Slightly less. Actually, I don't think we have the data for adults, but it is still very common, particularly because it's a neurological condition and the cough is a reflex. It's very common for silent aspiration to occur when no cough is seen. Wet, and these other subtle signs that we look out for that sometimes can indicate aspiration risk too. So wet voice, sounds a little bit bubbly or gurgly, rattly breathing, wheezing, and increased work of breathing or increased effort to breathe, lots of huffing and puffing and moving, head bobbing up and down, any sort of change in breathing If you notice that it wasn't there before the mealtime started, and then as the mealtime progresses, you notice, hey, that little rattly sound wasn't there before. It could be because there is something going on or they're at risk of dysphagia. For babies, it could be difficulty sucking, or even with adults, difficulty sucking from a straw, forming a seal with a bottle, a cup, or straw, or a spoon. Any residue or food left over in their mouth after a meal, if you find a piece of rice or two in their mouth a couple of hours later, sign of dysphagia. Difficulty biting or chewing the food, losing a lot of food from their mouth or drink from your mouth, glassy or watery eyes, a colour change in their face, either going dusty or really flushed in your cheeks. Fatigue is a big one. Excuse me. If you're having trouble breathing, you're more likely to get tired during your meal, and you need more effort to be able to get through that meal. So fatigue is very common, falling asleep. Any vomiting or discomfort, arching, pulling back, repeated gagging that happens with most meals. Constipation can indicate that they're not getting enough fluids. Recurrent chest infection obviously is a big one, and not always aspiration pneumonia. Aspiration pneumonia is actually quite difficult to diagnose. Okay, I'm going to show you some videos of what aspiration looks like in an animation first, and then an X-ray swallow study. So I'll just pull up the videos for us here. I'll show you what a normal swallow looks like first. Okay, so this is a normal swallow. Excuse me. So you see this person putting some food into their mouth in a moment, doing a bit of chewing, and then you see their airways closing over appropriately just as the food moves to the back of the tongue. So our airways close over to protect any food or drink going into our lungs. You'll also notice that the soft palate at the top and back of the mouth closes over to prevent any food and drink coming out of our nose. All right, so that's what a normal swallow should look like. Very timely, it happens very quickly. Now I'm going to show you what aspiration after the swallow looks like. So this is where the swallow happens, and then after the swallow, the airways open up again, and there's still, in this case, liquid in the airways, in the pharynx, which then trickles down into the airways as it opens up again. So the oral stage looks quite good. And then the swallow happens. The swallow is timely as the liquid gets to the back of the tongue. But then the airways open up again a little bit too soon, and the movement within the pharynx is a little bit slower. Okay, I'll show you the next video, which is an X-ray video. So when speech pathologists are concerned that there is a risk of aspiration, we will speak with the physician of that person who is potentially at risk, and we will organise what's called a video fluoroscopic swallow study. So yes, we'll order a video fluoroscopic swallow study, or FEES, which stands for fibre optic endoscopic evaluation of swallowing, which is where a camera goes down the nose and looks into the entrance of the airways to see what's going on. The video fluoroscopic swallow study, which is this X-ray video that I'm about to show you, is the most common. These can also be used where if it's a repeated study that you want to do several times and you don't want to expose the person to too much radiation, you might do a FEES. Or if they're nil by mouth and you want to see if they are aspirating their saliva, or you want to do it in a natural environment rather than a fluoroscopy suite in the hospital, which can be quite daunting and very unnaturalistic. So I'll show you the aspiration before the swallow on the video fluoroscopy. So here we go. This person is trying to chew some food. It's in their mouth. They're taking a little bit of time. You can see a large chunk of food that's not being well chewed, and that's about to tip into the pharynx while the airways below are still open down here. So some food went down into the esophagus, but then you saw some coming forward into the airways. And watch it again. So the person's trying to chew. They don't have great control in their mouth, and it's coming down into their pharynx without great control. The swallow hasn't happened yet. The airways are still open. Some food went down the right way, and then a big chunk went down the wrong way, and that person is trying to cough it up. So that's quite an extreme version of aspiration on a large piece of food. And then we're also going to have a look at the last one, which is residue in the pharynx after the swallow happens. So we'll talk about thickening fluids later, but thicker is not always better. As you'll see in this instance, this person is having a drink, but the muscles in their pharynx are not strong or coordinated enough to clear all that fluid in their throat. So some of it gets stuck on the pharyngeal walls. Even after the swallow, there's a lot of residue inside their throat or inside their pharynx, which can then trickle into their airways. Okay, so some red flags to look out for include stress during meals, concerns with weight or growth, trouble breathing during or after the meal as well. So there could be trouble breathing if they have after the meal, if they have reflux coming back up, that then might go into their airways. And there are any recurrent chest infections or pneumonias, coughing, gagging, choking when eating or drinking, meal times that are quite long but take more than half an hour, where the person starts to get fatigued and tired and burns more calories at that point, so they're not getting as much nutritional intake or caloric intake because they're burning a lot after 30 minutes. Any reflux, heartburn, vomiting, taking reflux medications or using any thickeners, and constipation or dark urine with a strong odour, all things to look out for. So now we'll touch on how we can help. So they're all the things that can go wrong. We need some positives, right? Okay, so interventions or treatments fall into three main categories. Compensations, which are often necessary because they immediately improve safety and reduce aspiration risk or improve efficiency. They improve functional improvement as well. They work by adapting or simplifying the task, and they can also use alternative equipment to make it easier or increase independence. Then there's skill training. So these aim to improve skills, and they fall into two categories. Indirect, which don't use any food or drink as a stimulus, or direct, which use food or drink as a stimulus. And that direct intervention is what we are trying to aim for if and when we can, because the best treatment for swallowing is swallowing. It's just like if you want to learn how to play a piano, you're not going to learn how to play a piano by just tapping your fingers on a desk at home. You need to practice playing the piano. You need to practice reading the music. You need to respond to all of the stimulus around you, the pressure of the keys, the sound that you're hearing, the timing. All of those things are what make you a great piano player. You can never get there just by tapping on your desk at home. The same applies for indirect interventions. They can be useful if a person is nil by mouth or not safe to swallow, or we really want to intensively improve, say, chewing strength or tongue strength, but you're much, much better off trying to do that with food so you can stimulate a swallow and it's closer to the real task. So we'll talk about compensations first. This particular slide is for babies specifically who are breast or bottle fed. So positioning, we want the ears and above their shoulders. This is elevated side lying in this picture here, where the child's bottom is pressed up against the parent's stomach. Their head is slightly elevated, which you can't see in this picture, but they're nice and flexed. So the hips have a 90-degree position. Their arms are up right by their mouth, which is where we want them. That's flexion. They're very comfortable and stable there. We can also work on timing changes, so changes to their routine to make them more hungry, or shorter, more frequent feeds if they're fatiguing quite quickly. And we're really reading and responding to their cues. So if they're telling you that they're ready for a feed, giving them a feed at that point. If they're telling you that they're tired or that they're stressed, responding to those as well. And you can sometimes do some preparation at the start of the meal, like sucking on a dummy or dipping a dummy in milk, or making it really child-led and fun and doing lots of food, play and exploration with their hands. For older children and adults as well, these are some of the things in terms of positioning that we want to try and avoid. So this first picture shows a child who is really leaning to the side. We want to try and get midline positioning as much as possible, because that's much easier to coordinate all the muscles in your mouth and in your throat and make sure that everything goes smoothly down the right way. This child in the second photo is twisted to the side and their head is also twisted. Again, they're not in that midline position, so it's harder for those internal muscles to work and move things down the correct way. And this person in the third photo, their neck is extended back like this, which is what we call a CPR position, right? If you're doing CPR, you're extending a person's head back. You're wanting to open up their airways to do that so you can get air into them to do CPR. Their head back in this position also opens up their airways, which is not great when it comes to eating and drinking. And the reason for that is we saw in those videos earlier that the epiglottis, that little flap that closes over the airways, is only a fixed distance long. So if we expand the airways by tipping our head back, that space increases and the epiglottis can't fully close off the airways or protect the airways as it should. Generally, what we're trying to aim for is what's called a 90-90-90 position. It's not always possible in people with cerebral palsy, particularly if they have very complex seating issues, contractures, or any physical scoliosis. Those sorts of things as well can be quite difficult, but we want to try and aim for it where possible. And that's where you have 90 degrees flexion at your hips, 90 degrees at your knees, 90 degrees at your ankles. Also, your arms and elbows can be at 90 degrees, and we want your chin in a nice neutral 90-degree position as well. This person here is showing that perfectly. And the reason that we want that is because all of those joints are in flexion, and swallowing, sucking from a straw or a bottle, chewing, they're all flexion movements. And if you want to encourage a flexion movement, you need the rest of your body to be in flexion. If the rest of your body is extended out, with your neck out, your arms out, your hips in an open angle, that encourages extension elsewhere in your body as well. So it's really hard, like we saw at the beginning, when our neck was extended up, it's really hard to swallow when your whole body is extended. So have a think about that. We also want our feet to be well supported. If you think about when you go out, perhaps to a bar, the first thing that you're doing when you're sitting at one of those tall tables is trying to find somewhere to put your feet on to stabilize yourself. And if there's nowhere to put your feet on, you're going to try and stabilize yourself with your hands on the table. And if there's nowhere for that to happen either, you're going to be like, let's get out of here and find the next bar to go to, because you will be very uncomfortable, distracted. You're not going to be able to have that conversation with your friends and peers in the same way as if you were sitting really comfortably. And so if you're sitting comfortably and well supported in flexion during a mealtime, you have more capacity to focus your energy on what is going on in your mouth, in your throat, and the social environment around you, so that your eating is much more efficient and much more safe. And if you need support or assistance with meal times, having them on the same eye level as you and in front of you, so you're not having to turn, is also a great strategy to use. So I touched on the principles of neuroplasticity and motor learning before when I was talking about the piano analogy. And the main ones for us to remember are you have to use it or you'll lose it, or use it and improve it. And intensive practice is the best treatment, and it has to be as close to the real task as possible. So we want it to be intensive in 3 forms. We want the load or the resistance placed on the system to be challenging. We want lots of repetition, and we want lots of practice over time as well. So keep those 3 in mind when we are thinking about the ways to practice. Now, some other compensatory strategies are, this is what's called the IDSI framework, so International Dysphagia Diet Standardization Initiative. And so thickening fluids fall under these categories at level 1, 2, 3, and 4. And then modifying foods, which we'll touch on later, fall under levels 3, 4, 5, 6. And 7 is the regular or the easy to chew levels. So they're really easy to test. So there's commercial thickeners that you can buy from the pharmacy. Your speech pathologist will guide you, hopefully with a swallow study alongside that, to give them some objective information. But then you'll need to do some really easy, quick tests at home with a 10 ml syringe, a special 10 ml syringe. And I'll show you how those tests work. We'll watch a quick video. Okay, and I'll talk through this video for those who can't see it. All right, so there are 3 syringes, and they all start out with 10 mils of fluid in them, one at level 1, which is slightly thick, one at level 2, which is mildly thick, and one at level 3, which is moderately thick, and a 10-second timer is going. And then after 10 seconds, the fluid that drips through is stopped with the person's finger, and then we check how many mils is left over in this syringe after 10 seconds. And from that, we can compare it to this guide here. So if there's between 1 mil and 4 mil left in the syringe, then it's a slightly thick fluid. If there's less than 1 mil in the syringe, then it's what's called level 0 or thin fluid. If there's between 4 and 8 mils left in the syringe, it's a level 2, mildly thick. If there's between 8 and 10 mils left, it's moderately thick. And if there's more than 10 mil, or not more than 10 mils, if all 10 mils is still left in the syringe afterwards, then that is extremely thick. And there are alternative ways to test for extremely thick with a fork or a drip test on a spoon. Okay. Oh, let's put it on video again, which I don't want. All right, and then we have modifying food textures. So we spoke about those briefly. Level 3, liquidized. Level 4, puree. Level 5, mince and moist. Level 6, soft and bite-sized. Level 7, which is regular food. Now, I just want to take a moment to appreciate how beautifully these foods are presented, particularly the puree, which is piped out in, these are all carrots. But the puree is piped out using a piping bag into the shape of a carrot. It's just, it makes the food seem so much more appetizing and tasty rather than just a bit of slop on the plate. We'll watch a quick video, the IDSI levels. 3, 4, 5, 6, and 7. So this is 3, the liquidized version. You'll see that it's dripping through the tines of the fork. And the puree is quite thick. It doesn't drip through the tines of the fork, and if you use a flick test from the spoon, it comes on in one heap, and there's no lumps in this. This one is minced and moist. So you'll notice there are small lumps within that. So for children, those lumps are 3 mils, and for adults, those lumps are 5 mils. They're the guides. And these are soft and bite size. So for children, these sizes are 8 mils, and for adults, they are 1.5 centimeters in size. And then this is level 7, easy to chew. So these are all the tests that you can do to make sure that they fit within those IDSI framework guidelines. Okay. So other compensatory strategies that we can use are modified cups and utensils. Offer the person extra time between each mouthful, go a little bit slower. You can prompt them to clear any residue that might be in their mouth or perhaps in their pharynx. You can use that by just giving them a verbal cue or a tactile cue, perhaps touching them on their face, or offering an empty spoon, a clean spoon, between every swallow to help clear any residue in their mouth and help to prompt another swallow from happening. A liquid wash you can sometimes use if there's food left over, but use this with caution because it will create what's called a mixed consistency where you have a solid and a liquid together, which is actually the most difficult consistency to manage. You can provide external jaw or lip support or add some extra sensory feedback. If you can feel what's going on in your mouth more, it's much more easy to control. So adding some extra crunch by putting some croutons or crumbled up toast on top or crumbled up cracker, increasing the temperature. So rather than sort of room temperature food, making it warmer or colder, again, you can feel it in your mouth better, and heightening that flavor a little bit, putting some salt in there, some pepper, some spices, or some lemon in there to add that extra sensory feedback. So indirect interventions are the ones that we want to try and avoid if we can, but they're sometimes necessary to increase that muscle strength if needed. But really, most of the time we can do that using food. Remember, the best treatment for swallowing is swallowing. So these are things like sucking on a dummy or a pacifier for babies, or trying to increase jaw strength by biting on firm silicone tubes. Instead, you can try and bite down on celery sticks or really firm, hard, thick carrot sticks. The head lift exercise or shaker exercise is where, mainly for adults who can follow instructions quite well. There's not a lot of research in CP, mainly in the stroke community, the same for the Masako maneuver. Where you lie down and you do certain reps of bringing your head up and looking at your toes, and the Masako maneuver, which is where you stick your tongue between your teeth, you bite down and hold it there, and then you swallow. Again, not much evidence in CP. For direct intervention, so these are the ones that follow those neuroplasticity, so really work at trying to change your brain. Direct intervention, so start with the highest IDSI level that is safe for about 3 to 5 mouthfuls. So you know that it's challenging beyond those 3 to 5 mouthfuls, so that's a good level of challenge to aim for. You can slowly increase the size of those mouthfuls by starting with them quite small and then progressively making them bigger. And starting with them slow, lots of time in between each mouthful, and then increasing those timing of mouthfuls, getting them to be able to do that faster. Practice these difficult textures 3 times a day during snack times, and make sure that you're constantly increasing that just right challenge. Progressive overload is really important. So when you can manage more than 5 mouthfuls, you can start generalizing that to your meal times, mixing it up with, a mouthful of some firmer to chew foods, mix with a drink, mix with some puree. So you're making it even more challenging. Then we can do some environmental changes. So we want the environment to be nice and calm, to avoid that fight or flight mode. We don't want the mealtime to be stressful. And what happens when you're in fight and flight mode is your body and your brain is telling you there's something trying to attack you, a lion. And the last thing that you want when a lion is trying to attack you is for you to feel hungry. So your body switches off your appetite altogether. So if you're stressed during meal times, you are not going to feel hungry at all. You also need to be motivated. So salience really matters. If you want to work on your eating and drinking, you're going to do much better than if someone is forcing you to try and do it. We want a really nice, relaxed, pleasant environment, and we want to encourage participation and inclusion for everybody who has dysphagia. And their communication is also essential. So make sure you know their best method of communication when they're eating and drinking. If they use an alternative or augmentative communication system, have that available, know how to use it with them. It increases their independence. And we know the more independent the person is with their mealtimes, the less likely that they are at risk, because they can tell us when they need a break, when it's too much, when they want more. It gives them more control. They can also tell us if they need help. They can choose what types of food they want, whether they want to eat now. It gives them more autonomy and control over their mealtime. And also it allows opportunity for social interaction. So I want to touch on feeding tubes. So sometimes feeding tubes are necessary. So it can be a nasogastric tube in your nose. It can be a tube that goes directly into your stomach or bypasses your stomach altogether. Sometimes these are necessary life-saving interventions. They support nutrition, hydration, medication, and they can minimize your risk of aspiration. It doesn't necessarily mean that you can't eat orally. Most of the time, if you have a feeding tube, you can continue to work on your eating skills alongside it. In fact, giving you the energy that you need and nutrition that you need can often give your muscles more stamina and strength and ability to improve and progress. And a lot of the time, feeding tubes are temporary. If you are nil by mouth and you have a feeding tube, you can still take part in meal times, absolutely, and you can still be included in meal times. I want to touch on oral hygiene as well. So in order for aspiration pneumonia to occur, we need a trifecta of three things happening. We need aspiration, where food or drink goes down into your lungs. We also need a compromised immune system where your body can't fight off that foreign body in your lungs. And we need bacteria to go along with it. And the most likely place that that bacteria is going to come from is from within your mouth. So oral hygiene, brushing your teeth are all very important when it comes to minimizing risk of aspiration pneumonia, particularly if you're very high risk of aspiration, and especially if you are nil by mouth and you don't eat orally at all. Often we think, oh, they don't eat or drink orally, you don't need to brush their teeth. But actually, when your mouth is stagnant because you're not eating, you're producing less saliva, there's less stimulation of all the bacterial environment going on, so it can build up in your mouth much more so. If you think about an ocean, there's lots of current and things moving back and forth, compared to a pond that can get a bit smelly with lots of bacteria growing because it's stagnant, it's not moving so much. The same can happen if you're nil by mouth. Within your mouth. And because you're nil by mouth, most often you are a very high risk of aspiration. So combine those two. Just remember, nil by mouth, really, really important to do oral hygiene at least twice a day, before and after every feed if possible. Now, the last thing that I will talk about is eating and drinking with acknowledged risk. So the aged care quality standards talk about the right to make informed choices, the right to be supported to take risks, to live the life that you choose. And the Charter of Aged Care Rights talks about the right to have control over and make choices about your own care, your personal, your social life, including where those choices might involve some risk. So at the end of the day, you have the right to make an informed choice about the food and drink that you eat, even if there's risk involved. And you can discuss this and develop a plan with the service provider that you use, if you're in out-of-home care or in a day program, and your speech pathologist to help you make the decision that is right for you. And that is all. I will open the floor up to questions.
Thanks very much, Amanda. I'm just going to give attendees a few moments opportunity to submit any questions they may have in the Q&A chat box, which is at the top bar there on Microsoft Teams. So I'll just take a moment to say thank you again so much for that presentation. It It was really informative, and we had a lot of interest in this subject matter. It's obviously something that affects people with cerebral palsy very broadly. And for people who are in a role of a parent or a caregiver or another supporter, it can be daunting to know the nuances of dysphagia. So it's something that's very useful for them, and can be often difficult to find the right information that they know is reliable or credible, and applicable to their situation. So in a way that connects to the mission of My CP Guide. If you're not familiar with My CP Guide and you're attending today, basically My CP Guide is a free platform which provides an information hub all about cerebral palsy across all life stages of the condition. So if you've not checked it out before and you're attending today, I encourage you to take a look at mycpguide.org.au. It's completely free to use. There's a very significant breadth and depth of information there on a whole variety of different topics, not just relating to healthcare, but also general lifestyle matters to do with a person with cerebral palsy. So our goal is for it to be useful for anyone who needs more information about cerebral palsy, and it wants to know that the information they're accessing is reliable and up to date and credible. Everything that's on the site is drawn from sources all around the world and vetted to make sure that it is that high quality. So I'll just start here by reading a couple of these questions that we've received in the Q&A area. And Amanda, if you want to answer these as you wish. So first we have a question that says, great information. I wish I had known this several years ago. My sister passed away in December 2023. She was 89 years old. Doctors don't seem to know much about this. How can this be changed, is what this person asks.
Yeah, I think that's a great question. And I want to start off by saying I'm very sorry for your loss. It is such a challenge to deal with the loss of a loved one and a family member like your sister. But it sounds like she had a great support around her within you. You are absolutely right. There aren't many doctors that know about it. Most of them don't get any training about dysphagia when they are doing their undergrad degrees. I'm trying to change that with our team. So the more that this information gets spread, the better. I work on a multidisciplinary feeding clinic, and we often get medical students come in to sit with us, and we are planning to go out and do some lecturing of medical students as well. But any opportunities, we're always welcome for doctors to come along, ask questions. The other thing that we do is which is quite common, if we need a swallow study like a video fluoroscopy or a FEES, then we'll need a referral from the doctor, or sometimes the doctor will refer to us if they just don't know what's going on. In which case we can write a very comprehensive report and start building that relationship and write some of the information there that they will hopefully read. But yeah, it is a huge challenge. And often, like I said, sometimes you'll get aspiration pneumonia that gets diagnosed as asthma. So I think it also really comes down to families advocating for and really knowing the ins and outs of the symptoms and the signs of dysphagia that they're experiencing too. So you can try and tell them that it's not something that happens all the time. It only happens when they're eating and drinking, and at other times they're fine. Oh, I think you're on mute, Oliver.
Thanks, Amanda. I just want to check, Wade, did you have a question? I just see you have your hand raised there.
I did indeed. Amanda, thank you again for such an informative presentation. You towards the end, you touched upon oral hygiene, and with everyone, regardless of disability, needs to go see the dentist to have, maintain good oral health. I know from personal experience as a child, even though, I could eat and drink just fine, I found going to the dentist terrifying, mainly because of the position that they would put you in order to to work on your teeth. So, especially given concerning parents of young children that have dysphagia, uh, do you have any advice for them on how they explain to dentists um, any helpful tips that they can provide so that their child can have a pleasant experience at the dentist?
Yeah, I think that is such a great one. And positioning is a good point there that I actually hadn't considered. But yes, you're right. The dentist, even for me, can be daunting and scary, and I know what's going on, right? But as a child, particularly a child with CP or a person with CP who has quite strong extension or tone in your jaw, it can be really uncomfortable too. I think a similar thing that to what we were talking about with trying to increase awareness with doctors, you could do the same with dentists. There are some phenomenal dentists who have lots of experience with disability at most children's hospitals, and I will always refer my clients to go there. Within Cerebral Palsy Alliance, we also have a voluntary dental clinic that runs once a month at our Lambie site. And I think Facebook groups can be quite good for this, because disability, not just CP, but disability for kids is much, much more common. And there are lots of kids, particularly kids with autism, who would find the dentist incredibly distressing. So you might find some recommendations of good dentists who know how best to support and are open to flexibility through some of those Facebook groups, perhaps.
Yeah, those are great suggestions, Amanda. And from my personal experience as an adult, knowing that I know how to explain the issue to a dentist, what I usually do is explain, and it relates to your initial example of tilting your head all the way up and trying to swallow. They tilt you back until you're almost upside down before they start working on your teeth. So I've realized that, you know, if they can just slightly recline you, they can easily adjust the lever of their stools that they're sitting on in order to work on your teeth properly. Yeah. And that actually reduces the anxiety overall and enables you to swallow easier.
100%, yes. And if you can take if you're in a wheelchair, take your wheelchair along with you, or any special seating that you might have, if you can take that along too, particularly if it has a tilt, because that will allow the dentist to have a better look without necessarily messing up your positioning or putting you much at higher risk of aspiration.
Thank you.
Yeah, no worries.
Thanks, Amanda. We have another question here, and this person asks, is it worth considering VFSS before introducing oral intake for people with cerebral palsy? Would positioning be a barrier to participating in VFSS?
Yes, so VFSS is video fluoroscopic swallow study, which is the X-ray videos that we had a quick look at earlier. 100%, I think it is always a good idea to get in imaging, because we can only just guess. We don't have X-ray vision when it comes to doing a clinical assessment, and a lot of the time we are wrong, particularly if they don't cough. So they could be at higher risk than we think, or they could be perfectly fine, or want to take that risk, and we don't necessarily know how to manage that. If they are nil by mouth and non-oral, it is trickier, because you don't want to expose them to radiation many, many times to repeat it. You can repeat it a few times, but certainly not frequently. The thing is, if you're going to undergo a video fluoroscopy and you've had a long period, or perhaps your whole life, of never eating, the likelihood that what you will get in that 5-10 minutes of video is that it's not going to be representative of what you're going to be able to do if that's the very first time that you've tried it. So with your speech pathologist, you can work out ways to reduce the risk, perhaps by doing lots of oral hygiene care, maybe trying with some water, which is a lower risk of developing an infection in your lungs if you were to aspirate it. Modifying positioning, lots of things that you can try together to give you some opportunity to practice swallowing and practice eating and drinking in small controlled amounts before you go in for your first video fluoroscopy. Alternatively, you can do fees where you've got the camera that goes down your nose, which you can repeat multiple times. It can be a little bit uncomfortable to have a camera down your nose, obviously, so you need to be prepared for that, but that's an alternative option too.
Thanks, Amanda. This person says, hi, Amanda, thank you for your presentation. Is the direct intervention suitable for all people living with cerebral palsy? What are some limitations?
Yes, so the only people that it will be limited for is if they are completely non-oral, can't have any taste, can't have anything by mouth. Otherwise, absolutely, we want to go there as quickly as we possibly can. Compensations are great, but we really need to try and safely push them. So your speech pathologist can guide you there. But yes, most times direct interventions are appropriate unless you are totally not having anything orally.
Thanks. We have just a couple more questions here, so I'll just go through these last ones that we have on our list. This person says, I have a 10-month-old, no diagnosis yet, but very extended. Really hard to achieve flexed position. Would you ever go with extension inside lying, or would you work hard to try and get baby flexed for every feed? Any tips for helping to achieve flexed hips, etc.?
Yeah, I think all my dog's going, so many challenges today. Yes, if you can achieve flexion, that is your best option. In terms of trying to get flexion in the hips, for a 10-month-old, they would be on solids, I would presume. We're looking to sort of get away from bottle feeding at that point or progress past bottle feeding. So a high chair, you can work with your occupational therapist to try and get a nice, as flexed as possible positioning where your hips are really well supported, your trunk and your torso is well supported, and they can reach a tray in front of them. If they're very, very extended, I wouldn't imagine a 10-month-old would have contractions at this point. So mostly you'd be able to do that if you're doing bottle feeding. I will quickly grab a baby and show you. I'll stop sharing my screen so my video is a bit bigger. But you want to try and hold your baby like this with their hips in 90 degrees, and you can also hold under their knee like this to give them some flexion, and then try and encourage their elbows to come up towards their mouth. You can swaddle them in this position too, which might help, particularly those swaddles that have Velcro on them. You can really sort of keep them in place a bit better using those for feeding.
Thanks, Amanda. We just have one more question here, and this is regarding a specific product that's available. It says, when considering indirect practice items, do you have an opinion on the Australian product called the Myo Munchie, that's spelled MYOMUNCHEE, that helps build the muscles for chewing? Are you familiar with that product?
I've heard of it. I'm just quickly Googling it to see. Yeah, so it essentially looks like a mouth guard from what I can tell, and it has some resistance as you bite down on it with a handle for the parents or the baby to hold on to. Look, it might help with strengthening their jaw, but it's very unlikely that that is the main issue with a baby. And you can strengthen a baby's jaw with food, and when you can do it with food, they're going to have so much more success. So I don't have any particular issues with this product, but I think if you've got the opportunity to do the same thing using real food, with food that has resistance like that, then absolutely go for it. And you can use, if you're worried about choking and biting off pieces of food, you can use those silicone food feeder bags or the mesh food feeder bags, or even just wrapping food in calico. They're great too. And there's one other product called a side biter. I think I've seen it on Instagram. Which is sort of like, it looks like a gloved finger, but it has holes in it, and it's made of silicone. And you can try and encourage moving food to the side, and as they bite down, the flavors of the food come out of the hole. So sort of similar concept, but if you're wanting to improve chewing, you really need to try and teach the tongue to move side to side by putting food on the mouth. So the side biter might be a better option. Having said that, I've never actually seen the side biter, but it's just that you've got food and there's flavour coming out as you bite down that would make it closer to a direct intervention than the myo munchie would be.
Thanks so much, Amanda. We'll conclude the webinar here. So I just wanted to say thank you to everyone who's attended the live event. We will have a recording of this whole presentation available and sent out to everyone who registered later on. So if you wanted to watch anything back, including any specific slides, or if you wanted to share the recording on to anyone who wasn't available to attend the live event today, we'd really encourage that. I've just shared in the chat a link to a very quick feedback survey. Please, if you have the opportunity to do so, just spend 1 minute giving us some information anonymously about yourself and the types of topics you're interested in, because this really helps us put together these webinars with My CP Guide. So thank you so much, Amanda. That was a really comprehensive, very informative presentation. I know we had a lot of interest in this topic, so it was really excellent. Thank you so much.
It was my pleasure. Thank you.
And with that, I'll just close the webinar. Bye, everyone. Thank you.
See ya.